generation is those who didn't have formal qualification because there was no degree available. They ran the department like Dr. S.K. Mehta,
Yes.
Dr. Marana Gopal. The
Right.
third generation is those who had a formal qualification and they established a department. Balakrishnan and Habibullah and S.L. Burur like that.
True.
And now you can calculate what is your generation. So generation is like that. We
Yeah.
come under fourth or fifth generation myself. Maybe
Right.
you are a young man only, so maybe 10 or 11.
Very, sir. So we look upon you, Dr. Reddy, and all your generation as the real mentors and the role models. So we get so much of motivation, the things you do, and and even this whole ACT webinars, all your brainchild, the effort you put up to make it so successful. So really wonderful.
Thank you.
So you need all the accolades, applause, praise, whatever you can say.
This topic we thought very simple, but not very simple. It had attracted over more than 1,000 delegates today.
Okay.
All over the diarrhea in immunocompromised is really challenging. And the second is IBS. Even
True.
though, we think it is not challenging, but when it comes to the patient satisfaction and our understanding, so we have none other than Professor Ramakrishna to deal with diarrhea in immunocompromised and Uday Ghoshal on IBS. Mahapatra, your turn now, and Girish, your turn before we'll start it. 1 or 2 minutes.
Yeah.
Right.
I think this is really very important platform. Today, both the topics are very good. I think I have circulated to my residents also, so that they will all join today.
Very good. Very
So,
good.
True.
Very good. Girish, you are one of our Girish, are you there?
was there actually.
Okay, you are there. I think Shiva will be starting in 2 minutes. Okay, are you
Right.
ready? All right.
True.
Yes, sir. All right, sir.
Girish, your comment, and after that we'll start. Where is this? Oh. Now I have to go back to the first slide. No.
One question is there.
From
Good
first
evening.
slide.
Good evening, sir.
Good evening.
Good evening.
Hello. Good evening, Dr. Ramakrishnan. So
Good evening.
always a
First
pleasure
slide, sir.
to
Slide number 1.
listen to a teacher like you.
Okay.
Thank you.
Ramakrishna is none with the luminal disorders in our country. He has got his original work. All this is very important. And whenever you give a topic, he has never denied any topic. So that is a spirit of Dr. Ramakrishna. So there used to be in All India Radio when we don't have anything. Already the trusted and the tested the musicians will be there. So we used to call in Tamil Nilay with one. So like that the Ramki, you give him a topic, then he is always ready there. I smilingly will accept. So we are fortunate to have Ramki. Same is true with Uday also. Very passionate about the topic, whatever we do. And he really knows. And because of these two speakers and the topic, today all the TV people they say rating, no? So this time we have gone cross 1,000. Okay, I think this is a time now to start.
True.
All of you, please disappear and mute yourself. I bring warm greetings from Chennai, Tamil Nadu, India. We welcome all the delegates from all over the world who have locked in and the faculty. I am Dr. Chandrasekhar, your ACG governor for the India region, American College of Gastroenterology governor. I bring warm greetings from ACG as the members webinar subcommittee. At the same note, I also bring warm greetings from World Gastroenterology Organization, whose conference is going to be held in India this time As a member scientific committee of the WGO, I also bring warm greeting. And from my state, from the Tamil Nadu Dr. MGR Medical University, and from my institute, Medindia Hospital Academy. No. Sorry. First 4 webinar series saw the attendance of 24,000 delegates from all over the world. So that really inspired us, particularly when I am the ACG governor. I thought, why not we start the 5th webinar series? Because this is a digital platform where I can involve president of all societies, Indian societies and societies from UK, societies from the American societies, they are able to get in, including the Nobel laureate. So this is we gave a nice tag, name the topic, the world experts are there. And we have the another title, we have one new endoscopy webinar series called a news. And we created the news about the international webinars on gastroenterology. And the first series was inaugurated by none other than Professor Dr. Jonathan Lighton, the president of ACG. After that, subsequently, all president of American College of Gastroenterology, they came as the faculty and delivered their oration and lectures. And it is remarkable and unforgettable to have Professor Dr. Barry Marshall in one of the webinars in our series. And we gave I wanted him to talk about the journey of discovery of Helicobacter pylori and further, and what are the troubles he had taken to discover this, and how he had to convince the world scientifically with evidence-based the publication, the journey of discovery. And it's a fantastic, we had over 10,000 delegates from all over the world. From then onwards, our webinar, the standard had to be really made it a little more, and people expectation really started coming up. And these webinars have been possible because of my colleagues who coordinate with me, Dr. Gokul, Satya, Yogesh, and Prasad, and Dr. Krignana Samantha. One of them is Dr. Yogesh, the panelist today. And again, the success of the webinars because of these people who have really volunteered in themselves, and the just simple invitation, they are ready to give the attend these webinars as faculty, and both national and equally international faculty, and they were able to give the master oration and the lectures from this one. And equally the other gastroenterologists who have agreed to be the moderator panelists. So we have an entire list of who is who in gastroenterology in India and other Asian countries also. Very important. So that really made it very interesting for us. And we started this series from April 26 to October 26 for the time being. Then April, we started the neuroendocrine tumor classification management, gastrointestinal stromal tumor diagnosis and management, selection and optimization before liver transplant and post liver transplant care, physician's perspective. Now the third in this fifth series is diarrhea in immuno-compromised host and irritable bowel syndrome. And we're going to talk more about next July. I mean, this coming July, we are going to Dr. Patrick Kamath. He is going to discuss in clinics in alcohol-associated liver disease, and being the discoverer of the MEL score. How did I arrive at the MEL score? The journey and impact. And in August, we are going to have the state-of-the-art management in 2026 in ulcerative colitis, Crohn's disease by Dr. Vishal Sharma and Vineet Ahuja. And the September, we're going to have two other very important topics, dysbiosis and GI disease by Dr. Nageshwar Reddy. And antibiotic right choice is going to be by Dr. Usha Datta. And acute pancreatitis natural history by Dr. T.C. Vexandi from USA. And chronic pancreatitis natural history complication management. We will have more lectures from November onwards. I will be intimating to you. And Tamil Nadu Medical Council readily agrees to give it 1 credit hour for this. You can apply for this, those who are attending. So now coming to today's webinar series 5 on gastroenterology, two important topics we are going to be there. We have eminent speakers and moderators. It's my privilege and it's a great pleasure to introduce our speakers, Dr. B.S. Ramakrishna. He comes under the 2% of the world scientists in gastroenterology, both Dr. Ramakrishna and Dr. Uday Ghoshal. He's the director of Department of G in SIMS Hospital here in Chennai now. Earlier, the former professor and HOD CMC Vellore. He has got 50 plus years of experience as leading gastroenterologist. He has over 110 index publications. You name any the distinguished recognition he has got, past president of Indian Society of Gastroenterology. He has been the past editor-in-chief of Indian Journal of Gastroenterology. The host of the great awards, including the B.K. Ikat Oration Award of the Indian Council of Medical Research. We welcome you, Dr. Ramakrishna, for this. And this is going to be handled, moderated by our another good friend of ours, Dr. Harigan is a very busy clinician. He's a senior consultant gastroenterologist from Apollo Hospital, Chennai. He is very proficient in treating liver cases and chronic pancreatitis, and he's a good endoscopist too. He has got a wide-ranging areas of interest in therapeutic endoscopy, management of luminal disorders. We welcome you, Dr. Harigaran, for this meeting.
Thank you, sir. Thank you.
Thank you. And Professor Uday Ghoshal needs no introduction. My duty is to introduce him for the sake of the audience who have really logged in from all over the world. He is the former professor in HOD Department of Gastroenterology, SGPJ, Lucknow, and a chief of luminal gastroenterology and GI motility, Apollo Hospital, Calcutta, right now. He is the founder, member, and past president of Indian Neurogastroenterology and Motility. I think I distinctly remember he took up a different path from the routine clinician. And no one was interested or no one knew the value of motility disorders. He took up as a challenging, and he really now he's enjoying the fruits of his the different path he has taken. He's been the immediate past president of Indian Society of Gastroenterology. And he's got a wide interest in IBS, functional dyspepsia, GI motility disorders, gut microbiome, on. And he has a 433 publication. I don't know about now. This when I prepared the slide, it was at H index 76. And very proud to announce here, he has been the Rome committee member for functional bowel disease from India, one of the few Indians there. This is another going to be another friend of ours in Indian Society of Gastroenterology, Dr. Chetan. I thank you very much, Dr. Chetan. Now you are in Los Angeles for a visit, and you agree to be there with us. He's a consultant gastroenterologist and the gastro sciences. It's a Reliance Foundation Hospital and Research Center in Mumbai. He authored a patient information booklet titled Understanding IBD Patients for Patients and the Relatives. Yes, interest right from beginning. He knew the value of the luminal gastroenterology. One of the pioneers in this field from Mumbai, inflammatory bowel disease and motility disorders and advanced endoscopy. Core committee member of the Crohn's and Colitis Foundation of India. He has been the chairperson of the IBS Task Force, Indian Society of Gastroenterology. So two eminent speakers, two eminent, so we have Dr. Mahapatra, another senior gastroenterologist from Calcutta, and the Nirmaljit Singh Mahal. You can fit into anything, an endoscopy or motility and hepatology. He's an all-rounder. And we have Dr. Yogesh, very young, dynamic, very analytic gastroenterologist from our institute, consultant gastroenterologist from MedIndia Hospital, Chennai. This time what we have done is we have included 2 PGs as faculty so that they can interact with the world-renowned speakers like that. So this time we have 2 speakers, Dr. the faculty for the senior PGs, Dr. Lohit and Dr. Vignesh from Kilpak Medical College. So this is the full as thing we have now. I think with this introduction, I just want to thank my ambassadors from every state they're representing from Madhya Pradesh, Uttar Pradesh, and Dr. Greece from the Odisha. And you can just see how many of them are coordinating for the success of this webinar. And equally important is the international ambassador from our neighboring countries and all over the world, and also from the USA. They propagate the message like that. I take this opportunity to welcome you for the live workshop going to be held due live 2027 in February 26, 27, 28. Please block the date. And we are usually very interesting, the both lectures and the live workshop with this. With this, now I hand over the mic to my first moderator, Dr. Hariharan, who would introduce the topic briefly and invite the speaker. Okay, so this is what I just tell you about this. Dr. Hariharan, please.
Yes, sir. Am I audible, sir?
Yeah, perfect, Hariharan.
Thank you, sir. Thank you very much. First, at the outset, let me thank Professor TSC for giving me this opportunity to moderate this session with another great speaker, Professor BSR. We call him BSR. He is Dr. B.S. Ramakrishna, whom we fondly call as BSR. The topic for today is diarrhea in immunocompromised host, which is an algorithmic approach. When you talk about diarrhea, we normally think, think about diarrhea in an immunocompetent host or who has got a full immunity, where it is usually some sort of a self-limiting issue where you take, or if little goes away, moderate ones, you always give some treatment, you always get away with it, and you always think it is a minor problem. But the other way around, when somebody loses the immunity for several reasons, then when there is immunocompetent issues or when there is lack of immunity, you have a lot of issues. So diarrhea in an where the immunity is much less, where the immunocompetency is poor, then you have a lot of issues. Again, when you call somebody being immunocompetent, you know that they are immunocompetent. But when somebody is not having good immunity, the phenotype varies. It can be because they have been on immunosuppressant drugs, or maybe they are infected with a immunodeficiency virus, or they may have an hematological problem where their white cell counts are low, or there can be neutropenia, or there can be other things. These are all where when there is immunocompetency, when the immunity is less and you have a sort of an infection. Apart from this, you also have non-infective causes. So there is a different phenotypes for an immunodeficiency state, and there is variation when there is different types of diarrhea associated with different phenotypes of the immunocompetency state. So we have different problems faced by these people. Apart from it, there can also be diarrhea due to non-infectious causes, like when you are using a lot of transplant drugs, particularly transplant recipients. So quite a lot of variation, and it's quite a difficult state, and you have to act very swiftly. You have to make a diagnosis very quickly, and you should also make sure that you use the right tools to diagnose these problems. And for all these things, we have none other than a wonderful speaker who has got a great amount of interest in small bowel. Professor BSR will take us through this problems of diarrhea in immunocompetent hosts, and he will tell us what sort of algorithm to follow to manage these patients. Without wasting much time, let me hand over the mic to Professor BSR for his talk. Looking forward to your talk, sir. Thank you very much.
Thank you very much, Dr. Hariharan. Thank you for that introduction. Thank you, Dr. TSC. If I may just share my presentation here. Okay, there we go. So today we are talking about diarrhea in the immunocompromised host and see if we can have an algorithmic approach. Now, when we are thinking about chronic diarrhea and an immunocompromised host, there are two presentations that come to mind. One is a patient already known to be immunocompromised. For instance, mostly a lot of patients are referred to gastroenterologists by transplant physicians because they are immunocompromised, and when they get diarrhea, they refer to us. On the other hand, you can have a patient with chronic diarrhea who you do not know anything about. I mean, first off, he's coming in from the community, and it turns out that he or she has chronic diarrhea, and this may be the first presentation of immunodeficiency. So what I will deal with in this talk is to take you through an algorithm where we have an initial assessment, some basic tests, followed by stool studies. If you find a pathogen, then you treat it. Otherwise, you proceed to endoscopy and biopsy, tissue diagnostics, small bowel evaluation. And when you've gone through all this, then you still think about non-infectious causes, as Dr. Hariharan was saying. So let's start with the first one, the initial assessment. One, we need to assess severity, weight loss, look at the type of immunosuppression, and this is what Dr. Hariharan was talking about, that we need to understand that. And a medication review, because again, as pointed out, medication which is being used in these settings is in itself a cause of chronic diarrhea. So what is the cause of immunocompromise? And as I mentioned, the most common kind of patients that we see who are referred to us, who are immunocompromised with chronic diarrhea, are the organ transplant recipients. We have a long history of investigating patients with kidney transplants, bone marrow transplants, and more recently liver transplants and heart transplants. Secondly, there may be long-term steroid and immunosuppressant use in the non-transplant setting. Thirdly, we have to think about the acquired immunodeficiency syndrome, HIV, and lastly, the primary immunodeficiency syndromes. Now, coming to primary immunodeficiency syndromes, the ones that present with chronic diarrhea, I just briefly listed them here. Selective IgA deficiency, where the IgA is low, they have a normal IgG and IgM. They have diarrhea, they have celiac disease, they have nodular lymphoid hyperplasia of the small intestine. Then there's the Bruton A-gamma globulinemia, which may be X-linked or autosomal recessive, absent immunoglobulins, presenting with chronic diarrhea and malabsorption. Hyper IgM syndrome, again here's the mutation. High IgM with low IgG and IgA, presenting with diarrhea and liver disease. Common variable immunodeficiency, which is the commonest one of the immunodeficiencies that we see. Although selective IgA deficiency is supposed to be relatively common, we see a lot of CVID. And they have low IgA, IgG, IgM, which is variable. They have diarrhea, nodular hyperplasia, IBD, and malabsorption. And the others are a little less common: severe combined immunodeficiency, the Wiskott-Aldrich syndrome, and chronic granulomatous disease. So when these patients are referred, the first thing obviously all of us do is to do the basic tests. We do a CBC, CRP, electrolytes, because these people have chronic diarrhea. They may be having hypokalemia, hypomagnesemia, and so on. Albumin, very important because they've lost albumin, they have a protein-losing enteropathy. Globulin is again very important because if you have a low serum globulin, think of hypogammaglobulinemia. If you have a high serum globulin, you may think of other things like immunoproliferative small intestinal disease or amyloidosis. And then HIV and CD4. And next we proceed to stool studies. So in fact, when you do the basics, the blood studies and then the initial stool studies, so you ask for routine stool microscopy to look for ova and parasites. Stool culture is always done, but it's not necessarily very informative. Clostridioides difficile toxins, we do the rapid tests now. I'm going to talk a little bit about acid-fast stains because the routine stool examination is not often very informative in patients with immunodeficiency and chronic diarrhea. And a lot of us now use multiplex PCRs, different varieties of which are available. So let's look at the GI pathogens in the immunocompromised. Here's a list of them. Among the bacteria, mycobacteria, particularly the atypical mycobacteria, are important. Avium intracellulare, Wolinski, Generense. Pathogenic forms of E. coli, Campylobacter, Clostridioides difficile. The non-oven Vibrios, this is not cholera, the non-oven Vibrios. The non-typhoidal Salmonella amongst the bacteria. Among the fungi are the Candida and the Microsporidia, which I'll talk about just very briefly later. Viruses, amongst which the most common that we're looking at is cytomegalovirus, but occasionally you find somebody with chronic diarrhea who has a norovirus infection. And then the protozoa are very important. So Giardia, although it's very common, the ones which actually cause severe chronic diarrhea, the ones here, which is Isospora, Cystoisospora, Cryptosporidium, and Cyclospora. And among the helminths, Strongyloides. So the routine stool examination, you're looking at things like larvae of Strongyloides, again the larva of Strongyloides here. But very often, when we are thinking about the pathogens which cause chronic diarrhea, it is these pathogens which come under what are called the coccidian parasites, which are protozoa. So among them is Cryptosporidium, Isospora belli or Cystoisospora belli. Both of these you can recognize on modified acid-fast stains of the stool. So that's really what picks them up. And then we have the Microsporidia, which are actually fungi, which are originally classified as protozoa, but now they are fungi. And they are picked up by a modified Mason trichrome stain. So whichever lab you use, your lab should be able to do these stains when you see a patient with chronic diarrhea. Now, I talked about these parasites, these protozoan parasites. Collectively, that's called intestinal coccidiosis. Now, intestinal coccidia actually can infect immunocompetent individuals, but then the illness is self-limited. In patients with immunodeficiency, it can cause chronic watery diarrhea, malabsorption and severe weight loss, anemia which may be due to any deficiency, hypoproteinemia. If the colon is involved, you may have bloody diarrhea. The symptoms usually settle with effective therapy, but patients may require maintenance treatment. In fact, nowadays all the HIV patients, when they're getting treated, they get prophylaxis for these, and so we do not see this to the same extent that we used to see in the past. I'll just very briefly show you the intestinal life cycles of these parasites, basically because a lot of gastroenterologists don't really think about this. I know you've done parasitology in third year or fourth year, and then it's a forgotten subject. But these parasites are like malarial parasites, in the sense that malarial parasites infect the erythrocyte and grow inside the erythrocyte. These parasites infect intestinal epithelial cells and have a life cycle similar to the malarial parasite inside the epithelial cell. So here is Cystoisospora, this is Cyclospora, Cryptosporidium, which are protozoan parasites. The eggs are passed, the oocysts are passed in the stool, and then they are ingested, they sporulate in the environment, they ingested in contaminated food or water or hands, and inside the intestine, the sporozoites come out from there. They infect the epithelial cells, just like malarial parasites infect RBCs. The same is true for Cryptosporidium and for Cyclospora. Cryptosporidium, the only thing is that the oocysts, by the time they are passed, they already have spores in them. Microsporidia are fungi, as I talked about, but they look very similar to this, and the way they reproduce is also similar. All four are transmitted by the fecal-oral route, and they infect the small bowel. And the Microsporidia, there are two species. One is Enterocytozone bienniusi, the other is Encephalitozoon intestinalis. Sometimes it's necessary to make the distinction because one responds to flagell, the other will respond to what's a cotrimoxazole. The GI panel that we use, which is the molecular panel that we use at a hospital, is the BioFire GI panel, which there's about 22 different pathogens that it can detect. The thing is, sometimes you get multiple pathogens and you do not really know which of these is causing the chronic diarrhea, but nevertheless, it's a useful tool. So once we've done these tests and the stool studies, if you have found a pathogen, then you treat that. And what is the treatment? I mean, here I've just briefly listed the treatment. Here's cystoisosporiasis, which cotrimoxazole, cryptosporidia, not very effective treatment, but nitazoxanide, enterocytozone, nitazoxanide, encapsulitazone, albendazole, cyclospora, cotrimoxazole, strongyloides, of course, if we have thiabendazole, albendazole, and ivermectin. So if you haven't found a pathogen, then we go on to endoscopy and biopsy. And this is because in patients with chronic diarrhea, you're more likely to get information from biopsying the deep duodenum or the jejunum. And then you may follow it up with the ileocolonoscopy. And you take multiple biopsies. And in these, you do tissue diagnostics, including CMV, immunohistochemistry, look for AFB, do fungal stains, and do PCRs. And sometimes you may do a small bowel evaluation with CT or MR enterography, capsule endoscopy or enteroscopy. And basically with all of these, you really need tissue. And when you get the tissue, when you get a small bowel biopsy, you are most reliant on your pathologist to give you the proper diagnosis. So here's Giardia, you can see these here in a small bowel biopsy. Here's strongyloides, the larvae, in a small bowel biopsy. Now these two are easily recognized by most pathologists. And then you can have cryptosporidia, which again you see on biopsy. And here's an unusual one, which is cyclospora. These banana-like, so these are epithelial cells. These are all epithelial cells. You can see the cells here. And so these banana-like, they're like a sheaf of bananas. That's cyclospora. So this can easily be missed. In fact, it was missed by somebody and then picked up by another person. And then this is the modified acid-fast stain showing atypical mycobacteria in macrophages within the lamina propria. So once you've done this and you've got a biopsy, then you'll be able to treat these patients. Now, after all this, and you've also done a colonoscopy, ileocolonoscopy, maybe an enteroscopy, whatever, the diagnosis still is the same. Then we come to non-infectious causes. Non-infectious causes can include inflammatory bowel disease, can include drug injury, can include graft versus host disease, which is something that we see in patients who've undergone bone marrow transplant, and you can have microscopic colitis. Again, histology is very important in all of these. So the non-infectious chronic diarrhea, immunologic, can be GVHD, celiac disease, IBD. Drug-induced, of which mycophenolate mofetil is very important. Basically, this causes apoptosis in the crypt cells in the small bowel, maybe neoplastic. I just show another condition called malakoplakia. I've got a couple of interesting patients that I'll just quickly discuss at the end if I have time. So graft versus host disease, most commonly occurs after a bone marrow transplant, but can also occur with other transplants. And the diagnosis originally made by biopsy from the oral mucosa, but being gastroenterologists, we tend to put in a scope and take biopsies. So this apoptosis in crypts, destruction of glands, ulceration, submucosal fibrosis, and chronic GVHD. And as I said, MMF-induced enteropathy may also show apoptosis. Usually the GVHD occurs 3 to 16 months post-transplant, resembles autoimmune connective tissue disorders, and this may actually increase susceptibility to infections. And the target organs include the skin, the liver, and the GI tract. And in the GI tract, it may be diarrhea, malabsorption, and weight loss, which are the features. So 2 interesting cases. I'll just quickly go through these because it shows you the kind of progression of some of these patients. So the first case is actually somebody who had strongyloides. The 51-year-old who, as I said, this is the second type of presentation where they presented with chronic diarrhea. We didn't know this person was immunodeficient. So strongyloides, 51-year-old, presented in 2004 with watery stools, vomiting, and 20 kilogram weight loss. And stool and duodenal biopsy showed strongyloides, HIV serology negative, treated with ivermectin, recovered. And here's the duodenal biopsy showing the strongyloides larvae. Okay, so again, just to remind you, strongyloides, how it happens, it's actually what is called a geohelminth. The larvae, the eggs pass out in the soil or in warm, moist soil. They form these larvae, which then develop into free-living adult worms. Again, eggs are produced. Then you have the rhabditiform larvae, which infect you through the skin of the feet and then go through a pulmonary thing to get into the stomach, to get into the intestine. And strongyloides, although this says it is relatively low prevalence, I think along the coast we tend to have a lot of strongyloides. So this patient returned later with recurrent symptoms despite 2 courses of albendazole and ivermectin. So at this point of time, we did a little bit of literature search and found that another thing which predisposes to strongyloides is the HTLV1 infection. So he was tested and found to be positive. So this association between strongyloides and HTLV1 was first reported from Japan in 1984. In New York, 20% of strongyloides infected patients had HTLV1. In Australia, 2/3 of the strongyloides infected individuals had HTLV1. And it's transmitted from mother to child or by sexual contact or by contaminated blood products. And the HTLV1 infection can be associated with neoplastic diseases like T-cell leukemia and lymphoma. Inflammatory syndrome, which is myelopathy, which is tropical spastic paraparesis, and opportunistic infections. And basically what it does is it increases regulatory cells, the FOXP3 T regulatory cells, and therefore reduces immunity to strongyloides. So this patient, we kept giving him ivermectin once in 3 months. He remained well for a few years, then developed watery diarrhea, ascites, and severe weight loss. So ascitic fluid was exudative. We actually did a colonoscopy and biopsy and found that he had a GI lymphoma. This is what the lymphoma looked like. And when we stained the immunostaining positive for CD3 cells, which tells us that it's a T-cell lymphoma. So that was one patient. So, and the other patient that I will end up with is somebody with malakoplakia. This is again a condition that many of you would not encounter. It's that it needs a good pathologist to be able to discover this. So this was a 32-year-old post-cardiac transplant patient, 4 years on tacrolimus and mycophenolate, 1 year history of diarrhea, fecal incontinence, and weight loss. Endoscopies and investigations were normal initially. This was done elsewhere. he did not respond to empirical treatment for infective causes. So he was referred to us for opinion. And he did an upper GI endoscopy and a lower GI endoscopy, very non-specific findings, a little bit of erythema here and there, nothing that we could pin anything on. Biopsies were taken. Basically, biopsies, what they showed was that they showed these histiocyte-like cells in the lamina propria. And within these cells, you had these characteristic granules, the bodies, which are calcified granules, which are found there with the target appearance, targetoid appearance, which tells you that this is, they're called the Michaelis-Guttman bodies, and this is diagnostic of malakoplikia. And so this is a stain for calcium, which shows all these black spots, showing you so many of these deposits within the lamina propria. So this is basically an infection which is due to reduced ability of macrophages to destroy intracellular bacteria. Usually what happens is that E. coli get into these macrophages. And so this young man who's a police officer, we treated him with ciprofloxacin for 3 months and he recovered. And in fact, now 8 years down the line after this treatment, he's still alive and I see him on and off. And here we considered a change of immunosuppression but didn't do anything. So in brief, this is the algorithm. When you have a patient who is immunodeficient and has chronic diarrhea, so first thing is to assess severity, dehydration, fever, weight loss and nutrition, electrolyte disturbances. Review the type of immunosuppression, HIV, AIDS, is it organ transplant, is it chemotherapy, steroids, biologics and JAK inhibitors, or primary immunodeficiency. Review the medication, are they using MMF or tacrolimus, other things like metformin, antibiotics, immune checkpoint inhibitors, lenalidomide, bortezomib. Do the basic investigations, as I said, CBC, ESR, CRP, electrolytes, LFT, etc. Stool tests, which is microscopy and culture, C. difficile, modified acid-fast stains, modified trichrome stains, a multiplex stool PCR. If you identify a pathogen, treat. If you don't identify, then proceed to endoscopy, upper GI first with biopsies, next ileocolonoscopy and biopsies, histology, immunohistochemistry, tissue PCR, TB, CMV, and then a small bowel evaluation in case you're looking at a non-infective cause, CT, MR enterography, capsule enteroscopy, balloon enteroscopy. If the diagnosis is obtained, treat. If the diagnosis is not obtained, then you evaluate further, look for pancreatic insufficiency, bile acid diarrhea, endocrine cause of diarrhea, any other cause of chronic diarrhea. There's nothing to say that these patients cannot develop other causes of chronic diarrhea. So the take-home messages, when investigating chronic diarrhea in the immunocompromised host, exclude infection first, use targeted stool stains and PCR, endoscopic biopsy is often diagnostic, consider CMV, protozoa, medication injury and IBD. If you haven't made the diagnosis, re-evaluate if the first round is not conclusive. Thank you. I'll stop there and thank you.
Thank you very much, sir. That was an absolute, incredibly comprehensive review of the in compromised individuals. What you should really do. It is an very, I do understand it's a very exhaustive topic, but to do that in 20 minutes, you have given all the chances to make it absolutely clean, and everything was clearly explained what you should do. You had clearly said that what we should do, if is it infective, we should also look at non-infective causes. You have told what to investigate, and you have clearly explained that an early endoscopy is also a must. It should not be withheld for want of reasons. You have said different stages, like you have to go for a first round, then go for a second round. Obviously, taking the fact that first the patient should be stabilized before we take these actions. But in spite of doing all these things, I do understand many of the immunocompromised individuals can continue to have diarrhea for a very, very long time. But, it is difficult to manage at times. But, sir, are we going to take questions now or are we going to take questions at the end, sir?
And thank you very much. After the end of both the
Okay,
lectures.
sir. So we'll go to the question and answer at the end of session, sir. Thank you.
Thank you.
Thank you very much, sir.
Professor Rama, as usual, you made a very nice last chart. No, that one thing is real. That's very good. Incredibly, the informative. At the same time, you can have it on your desktop. What you have to do. I like that. Just penultimate slide you made it. Fantastic. That very comprehensive. At the same time, it really guides us. And what I liked it is non-infective causes, and they can have diarrhea like any other individual. Don't have to worry about all the time pathogen. So with this, I will hand over the mic to Dr. Chetan Bhatt, who will invite the speaker after introducing the topic briefly. Then we will come back again. Both the speakers, Rama and Hari, stay with us so that we will listen to Professor Uday. Mic to Chetan for your deliberation.
Thank you, TSC, for this privilege to introduce our topic and Dr. Professor Uday Gosal. Irritable bowel syndrome is a very common GI disorder. It is not associated with increased mortality. However, the quality of life suffers and also the increased burden to the healthcare system all over the world. Diagnosis of IBS has moved from diagnosis of exclusion to the diagnosis of symptom-based criteria. The symptom-based criteria allow clinician to make a very strong and probable clinical diagnosis. Now, investigations are always there for the IBS, and many people do a variety and large list of investigations. However, the investigation should be only to exclude organic diseases, and whenever there is a alarming symptoms, one should investigate for the specific diagnosis. The serological testing, like for celiac disease or any other specific disorder, should be done only in a selected cases. Colonoscopy is reserved basically for alarming features, patients with alarming features, or in an elderly person with a probably age-related colorectal malignancy. In recent years, biomarkers have evolved to differentiate IBS from inflammatory infective disorders. However, there is no specific biomarker that can make diagnosis of IBS confidently. There are various gut microbiomes, there are immune markers and metabolomics which are holding promising results for the future. However, at present, there is no biomarker which can confidently diagnose. So in today's discussion, Professor Uday Gosal will talk about how to apply clinical criteria in practice, number one. Number two, how to apply the rational use of investigations in IBS cases and evolving role of biomarkers in diagnosis of IBS. I invite Professor Uday Gosal to take over the topic and irritable bowel syndrome, art and science of IBS. Professor Uday Gosal.
Thank you, Dr. Chetan, and for TS. Thanks to TSC for this great opportunity. The topic has been already introduced by Chetan. The topic is the art and science of treating IBS. So these are my conflicts. So the management pathway of IBS is important, and it is a stepwise process. The first job is we have to make a confident diagnosis, And when we talk about the confident diagnosis, what is important is you have to apply some criteria. I know many physicians don't really bother about the criteria, but these criteria helps you to actually improve your diagnosis and also reduces the need for investigation. Without criteria, you have to over investigate to exclude an organic disease. So therefore, I would say some criteria should be applied. Now, investigation is typically done in presence of alarm symptom. For example, a young man of 30 coming with constipation, you need not really investigate until unless that patient has alarm symptom. So what are the alarm symptoms? Alarm symptoms are recent onset disease. Second is age over 45 years at the onset. Third is somebody who is passing blood in the stool. Fourth, somebody has weight loss. Fifth, somebody has history of colorectal cancer in the family. So these are the typical alarm symptoms. So if these alarm symptoms are present, we have to really investigate. For example, a colonoscopy, maybe an ultrasound. But generally, let me tell you, in the clinics, in spite of making a reasonably positive diagnosis using different criteria, some basic tests are often done, and these include CBC, if indicated, thyroid function test, and maybe an ultrasound abdomen and stool microscopy and occult blood. But in presence of alarm symptom, patients should undergo more thorough investigation, particularly a colonoscopy. Now, once you have made the diagnosis, then it is important to explain to the patient the problem. Now, explain and educate about the condition. Also, I'll talk about later on multidimensional clinical profile, which was brought in Rome 4 and subsequently kept in Rome 5 as well. And this multidimensional clinical profile is very, very important. Look at his diet, lifestyle, and look at what could be his symptom triggers. Like somebody may say, whenever I take milk, I have this symptom. Somebody may say, whenever I take an apple, it triggers my symptoms of bloating. Obviously, this symptoms trigger must be found out, and this is what is personalized care. So that's why a busy gastroenterologist who may be doing only the pharmacotherapy is not the best way to treating this patient. Either he should have time, often it may not be there, and then he should have a team who can actually pick up those symptoms trigger. Pharmacotherapy is one of the mainstay of treatment, and we'll talk about what is refractory IBS and how to treat refractory IBS. As I said earlier, clinical medicine is very, very important when you are treating a patient with disorder of gut-brain interaction, which was called functional GI disorder earlier. A good thorough history taking, knowledge about each disorder and their criteria, and limited investigation are key to the diagnosis. For example, I've seen a lot of patients who have functional abdominal bloating, and these patients have been diagnosed as IBS, and then given, let us say, therapies which are antispasmodic. You don't expect antispasmodic to do wonder in functional abdominal bloating. Similarly, I've seen patients who came with cyclical vomiting syndrome, and now the patient has been labeled as functional dyspepsia. If you just be familiar with the criteria of cyclical vomiting, you will pick up. And in fact, it is not so uncommon in adult as well. Now, what is the criteria IBS Rome 5 criteria? We released Rome 5 criteria in May 2026. And if you look at this Rome 5 criteria, These are very similar to Rome 3 criteria. In fact, Rome 4 criteria became too restrictive, and that led to a lot of patients of a particular diagnosis, for example, IBS, becoming diagnostic orphan or moving to another functional GI or DGPI category. So what is Rome 5 criteria? Recurrent but not continuous. Recurrent but not continuous. Remember, if somebody is having continuous abdominal pain, this is unlikely to be IBS, and you have to thoroughly investigate. Continuous abdominal pain day and night cannot occur in IBS. So recurrent but not continuous, abdominal pain or discomfort. So in Rome 5, discomfort has been brought back on an average at least 3 days per month. That means it is trying to say symptoms are really bothersome, occurring very frequently. In past 3 months, associate the 2 or more of the following. These symptoms must be related to defecation, associated with change in the frequency of stool, associated with change in the form of stool. And when you talk about change in the form of stool, you must show Bristol stool form chart. Now, criteria symptom onset at least 6 months before. So if though the symptoms are now there for last 3 months, but the onset should be at least 6 months before. And the abdominal pain and discomfort should not be related to menstruation. If it is happening with menstruation, think about an alternative diagnosis. Then you subtype. So how to subtype? This is typical Bristol stool form scale. Now this is type 1, which is hard stool, and this is type 7, which is soft or watery stool. So you see here, if somebody has no pain, but having only constipation, this is called chronic constipation. In Rome 4, it was called functional constipation, but we don't really like the term functional because the functional has a connotation to different physicians that this is psychological. And that's why we have deleted this term functional. And because we did not get a better terminology, we said chronic constipation. So if somebody has no pain, but has constipation, this chronic constipation. But if he has pain or discomfort of certain frequency, then you call as constipation predominant IBS. Now, if somebody has diarrhea but no pain and discomfort, this is functional diarrhea. The same patient, if he has diarrhea plus pain and discomfort, then this becomes IBS diarrhea. When the subtype changes in weeks to month, you say IBS alternating. For example, 1 or 2 weeks constipation, 1 or 2 week diarrhea without any treatment, then this is alternating IBS. But if somebody says my symptom changes in days, today I'm constipated, tomorrow I'm having diarrhea, and I'm not taking any medicine to relieve constipation, this is IBS mixed. And this is very, very important because if somebody has constipation predominant disease, you can treat by treatment which causes relieves constipation. On the other hand, if somebody has diarrhea predominant disease, you can treat by drugs which actually reduces diarrhea. But if somebody is mixed, it is difficult. So therefore, there we have to rely a lot on a disease modifying agent or microbiota directed therapy. Now you will ask me, how do you define constipation and diarrhea? Very important. Don't go by stool frequency because even a constipation patient repeatedly visit toilet. Look at the stool form, and if the stool form is Bristol type 1 or type 2, more than 25% of the bowel movement over 2 weeks, this is constipation. Whereas if it is type 6 or 7, more than 25% of the time over 2 weeks, then this is diarrhea. But you have to remember that this 25%, if it is constipation, he cannot have more than 25% diarrhea. Because if it is more than 25% diarrhea over 2 weeks, Also 25% more than that constipation, it becomes mixed or alternative. So to define somebody as IBS constipation, more than 25% Bristol stool form 1 or 2, but less than 25%, 6 or 7. Though in Asia, we realize that if you go by stool type 1 or 2, you miss a lot of constipation patient. So that's why in Asia, we say even type 3 is a constipation defining stool. Now, pain is very, very important because when somebody is having pain, what does it mean? That there is not only a pathology in the gut which is causing constipation or diarrhea, but also there is increased visceral sensitivity and there is an increased brain perception. So pain is a very important parameter to note, and presence of pain will move the therapy from one to another. On the other hand, absence of pain, more often there are issues in the gut. For example, if somebody has constipation but no pain, I'll be very serious about investigating him or her for colon transit and fecal evacuation disorder because this is more of a gut-related issue in the patient. Now, how to treat? Subtype determines treatment. For example, somebody has IBS-C. Some people will say, take more dietary fiber, take a lot of water, though they don't really work. And in fact, many of the patients who have IBS-C, along with abdominal bloating, which is commonly associated, if you give more dietary fiber, bloating and pain can increase. The reason is dietary fibers are insoluble fiber. They increases bloating to the maximum extent. Whereas when you give isabgula husk, it is even still better because these are soluble fiber and they do not increase bloating so much, but they also do. So therefore, I'll give drugs which don't cause bloating. Ileal bile acid receptor inhibitor, ilobixibat, that is important in constipation. Osmotic agents such as osmotic laxative, lubiprostone, linaclotide are important. And pro-motility agents such as prucalopride is important. Once upon a time, cisapride and tegaserod were there. These are withdrawn from the market. And in fecal evacuation disorder, you treat by biofeedback. On the other hand, if you look at the diarrhea IBS patient or functional diarrhea, then you can give several treatments. For example, they are often FODMAP sensitive. So therefore, low FODMAP diet will work. They may have bile acid malabsorption. So therefore, we can sometimes treat them with cholestyramine, cholestyramine, and cholesevalum. Remember, cholestyramine can sometimes cause vitamin D deficiency. Therefore, long-term use of cholestyramine, be careful about vitamin D deficiency. Gut microbiota can be manipulated by rifaximin and probiotic. Fecal microbial transplantation must not be used in the standard care treatment of IBS. Actually, FDA gives a black box warning about this. It should be only a research tool and not standard of care of treatment. Many of them have fast motility. Remember, whereas constipation patients have a reduction in the serotonin, therefore serotonergic agents such as prucalopride will be useful. The diarrhea patient often have excess of mucosal serotonin, so you may block the serotonin in them, for example, by giving drugs such as ramosetron, alosetron, ondansetron, and silancetron. Also, motility can be reduced by loperamide, diphenoxylate, anticholinergics including tricyclic, acimadolin and elaxadolin, which are opiate agonists. But remember, if you are giving acimadolin and elaxadolin, be careful. It can cause acute pancreatitis. So now pain can be treated by anticholinergic and otilonium and other agents. So let us look at this drug. The drug for constipation includes psyllium, polyethylene glycol, chloride channel activators such as lubiprostone, guanylate cyclase agonists such as linaclotide, serotonin agonists such as prucalopride. Diarrhea can be treated by antimotility such as loperamide, serotonin antagonists such as ramosetron and ondansetron, microbiota manipulators such as rifaximin, bile acid agents binding agents such as cholestyramine, cholesevelam. Whereas bile acid binding agent is helping diarrhea, bile acid receptor blocker that increases the amount of bile acid in the GI tract, such as ilobixibate, is useful for constipation. Abdominal pain can be treated by smooth muscle relaxation, including dicyclomine, peppermint oil, tricyclic, and SSRI. This is a randomized controlled trial of Isabgula husk from Isabgula husk in treatment of constipation in IBS in India. And what happened is, though 17 gram of Isabgula husk was useful to treat this patient, but abdominal bloating and flatulence was an important side effect. Here is a meta-analysis which showed the same, that it is effective, but as I told, it can cause bloating. Now, if you look at the drugs which work for reducing the pain and spasm, these are typically visceral, smooth muscle inhibitor. So this can be inhibited by muscarinic receptor blockers such as clindium, meveverin, or otilonium, which works through calcium channel, pinavarium, which can work through calcium channel, and cholinergic nerve terminal blocker such as anticholinergic. So that means muscle contraction occurs because of acetylcholine, one. Second is obviously this acetylcholine works through muscarinic receptor, so therefore muscarinic blocker. And third is ultimately depolarization of the muscle lead to calcium entry and ectomycin coupling, therefore blocking the calcium works. So here is the different drugs that meta-analysis of different drugs that are useful in the treatment of pain, and you can see meveverin, pinavarium, otilonium, and so on were useful. What is lubiprostone, plecanatide, and linaclotide? The drugs are available in the market. Increases the amount of water in the lumen of the gut. It works because it is a prostaglandin agonist. In a large dose, it can cause nausea and vomiting. Linaclotide is a guanylate cyclase agonist. Like cholera toxin is an adenylate cyclase agonist, linaclotide is a guanylate cyclase agonist. So therefore, it is useful by increasing the water content in the gut lumen. But what happens is that it has another beauty. The beauty is, I can see here, it also dampens the enteric nerve. So therefore, in large dose, it can reduce pain. So if I have a patient with IBS-D, I'll be more comfortable if I need to give either linaclotide or ilobixibate. I'll choose linaclotide over ilobixibate because ilobixibate may cause more pain. Linaclotide may reduce pain. What is ilobixibate? Ilobixibate is a bile acid absorption blocker. We all know that bile acid, which is produced from cholesterol, now it comes to the gut lumen, and there it does its job, that is fat digestion, and then 95% of it is absorbed from the ileum, and this absorption happens through ileal bile acid receptor. Now, ilobixibate blocks the ileal bile acid receptor, and therefore more bile acid is available in the gut lumen, which causes loose motion. So therefore, it is useful in the constipation patient. But about 4 to 10% can have abdominal pain as a side effect. Only thing is, since it works by bile acid absorption blocking, you should give it half an hour before meal. So Japanese give it in the morning, but obviously that is should be given before breakfast. We Indian gives in the evening, that should be given half an hour before dinner. How about probiotic in IBS? I don't think the strength of evidence is very great. for treatment of IBS with probiotic, but one symptom which most studies showed probiotic to reduce is abdominal bloating. And this is a randomized controlled trial that we published where 200 non-constipation IBS patients were given probiotic or no probiotic placebo. And what we found is it did reduce abdominal bloating. And the meta-analysis also shows the similar result. So now look at the central factor in IBS. There's a very interesting study that we did. We took patient of IBS in ulcerative colitis patients. So when ulcerative colitis patients are in remission, they can have continuing symptom and they may fulfill Rome criteria for IBS when they have continuing symptom. We looked at the inflammation and psychological driver among them, that is IBS with ulcerative colitis in remission versus usual common garden IBS. And we found whereas ulcerative colitis in remission patient more often have higher fecal calprotectin, actually they have less psychological issue and they have less severity of the symptom. On the other hand, usual IBS had more severe symptom, more psychological issues, and less actually increase in the fecal calprotectin. So what does it suggest? It suggests that inflammation associated IBS, such as UC IBS, post-infection IBS, they have less severe symptom, but they have less psychological driver. Whereas usual IBS has more severe symptom and more psychological driver, and therefore you can't forget the mind while treating IBS patient. So we use a lot of drugs which are typically used by psychiatrists, but this drug we use in a very low dose, and this is much less than what psychiatrists use, and we call this as visceral neuromodulator. Here is a meta-analysis of visceral neuromodulator. It shows data on tricyclic antidepressant. They are quite effective, and selective serotonin reuptake inhibitor, quite effective. Only thing is if somebody has diarrhea or non-constipation IBS will prefer tricyclic antidepressant because their side effect is constipation. Whereas if somebody has constipation, will prefer SSRI. But let us look at IBS patients who are now refractory. And this is, I'm showing a primary healthcare center where you will treat many patients of IBS. But obviously, a proportion of people will be refractory and they will move to tertiary care center. The question is what extra you can offer them in a tertiary care center. What is the frequency of refractory IBS? This is 25%. This is a Peter Horwell data from UK. He showed about 25% of IBS are refractory. So question is, refractory is defined when the symptom severity is high even after 12 months of treatment and the frequency is more than 25%. Somebody will say, how do we assess symptom severity? We assess by symptom severity scale, IBS symptom severity scale. It relies on abdominal pain, distension, satisfaction with bowel habit, and how much it is affecting the quality of life. Typically, it can score from 0 to 500. And if somebody has a score between 75 to 175, they are mild IBS, moderate is 175 to 300, severe is more than 300, and below 50 is complete remission. So this is what we use. Now, so in those patients, we must do multidimensional clinical profile. In fact, all patients should do multidimensional clinical profile, but in this patient, it is particularly important. So you look at your categorical diagnosis, it is IBS-D, IBS-C, and so on. Look at how much they are FODMAP sensitive, that means is their dietary trigger. Look at whether they are mild, moderate, severe, whether there are psychological comorbidity and whether there are physiological dysfunction. So what are these physiological dysfunction? IBS-C patient can have fecal evacuation disorder, they can have slow colon transit, and they can have a combination of the two. IBS-D patient can have lactose or fructose malabsorption, bile acid malabsorption, non-celiac wheat intolerance and FODMAP intolerance, small intestinal bacterial overgrowth and dysbiosis, immune activation, post-infection, including post-COVID-19 IBS. So diet is very, very important. When you treat IBS patient, diet is very, very important. Earlier, this was a very common question by the patient, doctor, what can I eat and what should I avoid? And in our young days, we used to think this was a difficult question, and typically we'll say, eat what suits you, avoid what troubles you. It is good to avoid milk. The useless answer. Today, dietary therapy of IBS has moved so much that the some patients are treated only with dietary modification alone. So what is the diet? This is called low FODMAP diet. IBS patients respond to low FODMAP diet. So what is FODMAP? Fermentable oligo, di, monosaccharide, and polyol. And you can see here, these are the diets which are low FODMAP here. And on the left side, the chart showed high FODMAP diet. So you can imagine that many of the diet which people consider to be healthy, for example, apple, for example, let us say all these vegetable like cauliflower, mushroom, actually they are high FODMAP. And high FODMAP diet actually increases. The FODMAP is not typically digested in the gut. They go to the colon, they are fermented, and they produce a lot of gas. And here is an Indian data. There are multiple studies from all over the world on low FODMAP diet in IBS. This is one randomized controlled trial of low FODMAP diet in an Indian patient of IBS. Now, I'll skip this slide. So what do you do first? You eliminate all low FODMAP food initially in your IBS patient. Now then, once the patient says, I have responded, which is 50 to 60% of the patient, now you reintroduce those high FODMAP food one after another, and you identify which are the high FODMAP food that troubles this particular patient. And then you restrict those for a long time and allow other high FODMAP diet, which are not the trigger of symptom. Now, this is management algorithm for IBS. I will skip this. It is a complex slide, busy slide, but whatever I've spoken till now, all are beautifully presented here. So this paper is Indian consensus on irritable bowel syndrome. You can go through, and it is a free full text on the net. Also in refractory IBS, you do augmentation treatment. So what happens is, this is the concept of augmentation. Those patients who are refractory have more issues such as life stressor, psychological abnormality, poor coping, abuse, and everything. And you have to give attention to this. And there, augmentation therapy include, for example, 2 neuromodulator, so that you reduce the side effect but increase the quantity of the neuromodulation. Also, you can use non-pharmacological therapy, which are the non-pharmacological therapy. For example, gut-focused cognitive behavior therapy, acceptance commitment therapy, gut-directed hypnotherapy, mindfulness-based stress reduction, and yoga. So the concept is that, like, for example, these are studies on yoga. Concept is all these lifestyle measure help this patient in addition to the pharmacotherapy, dietary therapy, lifestyle therapy, pharmacotherapy, all them may work together to improve symptom. In fecal evacuation disorder patient, we give biofeedback, and 60%, about 60% patient improve with biofeedback alone. So this is a very famous study published in Lancet Gastroenterology, which showed that if you are doing pharmacotherapy alone, typically delivered by a gastroenterologist, it is much less effective than multimodal therapy, as I presented, which include lifestyle, diet, and other therapies and explanation. Finally, many of these patients have overlap, including functional dyspepsia overlap, and this may be secondary to cologastric break. So therefore, what you do is that mainly you treat their lower gut symptom rather than giving PPI and making them PPI dependent. So lower gut symptom treatment may sometimes improve their upper gut treatment. And here is the Asia-Pacific guideline for managing functional dyspepsia overlapping with lower GI disorder. Thank you so much.
Professor Uday Ghoshal for excellent lecture. I think it was a very crisp and you covered all possible parts of the IBS, the art and science of IBS. I think it was an excellent lecture. Over for the discussion.
I think, Dr. Chetan, nice that you came from Los Angeles and moderating the session, and Ghoshal and Ramki. Now we will take up the questions and comments and the thing. But I'm going to start from the panelists because already moderators. Let me ask Dr. Nirmal and Mahapatra and Yogesh to start the proceeding. Then I will call upon the other moderator, Hari and Chetan. Nirmal, your turn, please.
So I think, sir, we had two really wonderful lectures, both by Professor Ramakrishnan and Dr. Uday Ghoshal. So they're made two complex subjects so simplified. So I think a lot of queries already been clarified. But I think first I'll start a question from Professor Ramakrishnan about the infectious and the non-infectious causes. So do in such cases, sir, there's a role of biomarkers now, distinguishing between these two entities in people who are immunocompromised for one or the other reasons? Or we have to go by the algorithmic approach of first detecting infection, if not there, and then going to non-infectious. So any biomarkers which can be of utility at this point of time? That is first to...
Yeah, that's an excellent question. Thank you, Dr. Mali. In terms of biomarkers, I guess the biomarker that we use most frequently is fecal calprotectin.
Yes.
Now, fecal calprotectin depends on the presence of neutrophils. So if somebody is deficient in immunodeficiency, if neutrophils are depleted, then obviously you're not going to get a high fecal calprotectin. Now, multiple studies have shown that calprotectin can go up even in non-immune conditions. So, I mean, it's not necessarily inflammatory bowel disease, but anything which causes a high neutrophil infiltration into the GI tract. So, it doesn't necessarily differentiate an infectious versus a non-infectious. For instance, it might go both in severe viral infection as well as in a severe graft versus host disease.
True.
So that would be a limitation of things like this, like calprotectin.
Okay. So it means the answer is will not be able to distinguish between infectious and the non-infectious etiologies, more between an inflammatory versus a non-inflammatory cause of diarrhea.
Absolutely, yes. It would, yes.
Right.
Would that, sir, one quick thing, would that change, I mean, depending upon the immunocompromised phenotype, whether it is from HIV, whether it is from chemotherapy or from other causes? Do we have anything to...
Absolutely, it would, because, again, it depends on what the basic immune defect is. If it's a defect in T cell function, then we know that it allows the overgrowth of, it allows the infection or chronic infection with viruses, with intracellular bacteria, and so on. So, for instance, like MAI, Mycobacterium avium intracellulare, or chronic norovirus infection would be more when there's a T cell defect. If there's a B cell defect, if there's an antibody deficiency, then it's more likely to be a chronic bacterial infection or maybe a chronic parasitic infection.
That means, Rama, you will bring calprotectin in a little earlier, along with the blood test and other thing.
Abs-
As Nirmal said,
I'm
all
sorry.
protecting will do it. You will do that to differentiate infectious or the non-infectious inflammation. When you do that call protecting little earlier in the algorithm,
Yeah, we could do okay. We could do have a calprotectin there definitely, but it's absolutely. So I think we haven't actually studied this. Because in most settings the chronic diarrhea in immunocompromised is not something that we see in large numbers like IBS. So to have a study which shows whether it's effective, we don't know. But no, I don't necessarily use it in my algorithm.
so you will not change it. Okay, Dr. Mahapatra.
Yeah, yeah, both are excellent lectures, I must say. My question to Professor Ramakrishna, if someone has come to you with chronic diarrhea, how sensitive is the stool biofile in detecting organism? And mostly they have taken the antibiotic beforehand. Does it change your biofile result, sensitivity of the biofile result?
So the biofire is very sensitive because like all molecular tests, it is very sensitive. But the problem is it specific? Because what you might do is you might get 3 or 4 pathogens showing up on that, and then you don't know which is the one that is responsible. On the other hand, it is useful in a very refractory case. For instance, if you wanted to find a chronic norovirus infection, then I think a biofire panel is useful in a situation like that.
Rama, how common it is more than one organism causing chronic diarrhea?
It is not at all uncommon. So if you look at the biofire algorithm, the biofire has its own algorithm. So it says if there are 4 pathogens, it says go back and do it again.
Okay.
Okay,
Sure.
Yogesh,
Bacteria doesn't affect, antibiotic doesn't affect the biofile result?
No. So antibiotic will affect it if it has got rid of the organism. But if the organism is still there, even if it's very small quantities, you will get it on the biofire.
Thank you.
Yogesh, you have a question and comment.
Yes, it was indeed a pleasure and an honor listening to doyens such as Dr. B.S. Ramakrishna and Professor Uday Ghoshal. And congratulations to Dr. T.S.C. Archie for bringing such doyens for enlightening us. And first question to Professor Uday Ghoshal. This concept of IBS-U and IBS mixed, how difficult is it to treat, and what are the visceral sensory modulators that we have to employ in cases of the mixed type of IBS?
Yeah, so very good question. So let me tell you, whenever somebody has IBS mixed, it is most difficult to treat because if you give them drug that cause constipation, like as you do for IBS-D, they will have problem. If you give them drug to cause diarrhea, which is typically used in patients IBS-C, they will have problem. So what we do in those patients is you go by therapies which don't actually cause constipation or diarrhea, for example, low FODMAP diet, for example, probiotic, for example, antibiotic like rifaximin. In addition, your question is what was the next part of the question?
The IBS unclassified,
Yeah.
do those patients?
It is like when you have IBS-M or IBS-U, both have the same problem because you cannot really give them drugs. Now, your next question was how about visceral neuromodulator in them? Yes. When we see this patient first, we try on the first line only dietary therapy and probiotic or maybe gut-specific antibiotic. If there is no response, the next level we go to visceral neuromodulator. So in the next visit, typically we'll give visceral neuromodulator. Now there, the maximum data are there with amitriptyline. In fact, if you look at the Alex Ford study, which was published in Lancet, amitriptyline low dose, typically 10 milligram, do very good to them. Also, many of the time, what you can do is that you can empower your patient. You say, I'm starting this drug. Don't think this is only used by psychiatrists and I'm giving it for your mental issue. I'm giving you for your gut, like cardiologists give calcium channel blocker for heart or hypertension. Similarly, we give for esophageal motility disorder, same is the issue here. And then we'll say that this drug may cause sedation. So therefore, I'm giving a low dose. If your symptoms are relieved with 10 milligram, keep it to 10 milligram. But if the symptoms are not relieved and you are not getting too much sedation, increase it to 15 milligram. So what you are doing is you are empowering your patient. And these patients really like empowerment. They should have drug where they can increase or reduce the dose and get relief rather than every time coming to us for a consultation. So that's why it's called empowering the patient. So dietary therapy, gut microbiota manipulator, and visceral neuromodulator with empowerment.
Yogesh, another question to Dr.
One question to Professor B.S. Ramakrishna. Is there a role for any empirical therapy when you come across these patients? And is there a role of, after treating the patient, keeping them on prophylaxis like we do for pneumocystis carinii? Is there a role when it comes to chronic diarrhea and immunocompromise?
Oh, absolutely. That's a good question. So I get a lot of patients referred from nephrologists, post-transplant patients with chronic diarrhea. And the first thing they want, obviously, is a CMV PCR in all of these patients. But it's also the other thing that we discover other things occasionally. But all these patients would have been treated initially for the protozoal infections that I talked about. In fact, empirically, they treat them even before they send off stool samples. Now, basically, to be intellectually, I don't like that. I like them to at least have a stool examination. And then you can start them on empirical treatment. It will be nice to have that, but you can't dictate what happens in practice. But so that's one part of the question. The second thing is, do they require, if we do find a protozoal infection, they do require long-term maintenance because the immunosuppression is continual. Indeed, they do.
Can I add one more, sir? In terms of immunocompromise, do you advise the other colleagues who are doing the immunosuppression to go easy on the immunosuppression in case you are finding that your infection is not getting resolved or it's too long?
In general, no, because in general, I believe that intestinal infections can be treated. And that I think that the organ is too precious to lose. So in general, I don't really tell them to do that. The only time we had that is when you have something like the malacoplikia that I talked about, which where we had to give the antibiotic, initially injectable antibiotic, for 3 months. And so under those circumstances, we negotiate with the transplant physician, but otherwise generally no.
Rama, I have a question. How is the mortality rate, chronic diarrhea in immunocompromised, particularly kidney transplant? We have seen a couple of patients that they don't respond to any kind of treatment. Ultimately, the nephrologist told me that they lost.
In my experience, though, the mortality is not high, except in the setting of bone marrow transplantation. With kidney transplants, if they have chronic diarrhea and you haven't identified a cause, then I think a lymphoma is another thing that you need to think about. I mean, that's something that is very likely to be there.
Acute rejection, the hyperrejection of the hyperacute rejection of the kidney and develop chronic diarrhea.
So, Ramakrishnan, in your own practice, what percent? Yes. Hello, Professor Ramakrishnan.
Yes.
Hari, I'm
in your own practice, what percentage of patients, despite very extensive evaluation for chronic or recurrent diarrhea and immunocompromised, they remain without an etiological diagnosis? And if so, what is your line of treatment during that period in such patients?
I think it tends to be a very ad hoc decision. So what happens is that firstly, percentages, I would say maybe about 30 to 40%, we may not end up with an answer.
Okay.
And so that is the question. That's where you have to keep doing it again and again. And that's what I mentioned in my last slide, that when you get back to it, you have to go through it again because the second time you may pick up something. And then, sometimes we fiddle with you might talk to the physician and fiddle with the immunosuppression, but you have to keep looking again and again. And generally, eventually, I think you might pick something up.
Okay. We'll call
Yeah, I
we'll
have
go
one.
into systematic because there are two PG faculty waiting, Mahapatra. I will come back again for the second round. Dr. Lohit and Vignesh, quick question to our speakers or moderators, other panelists. Can you just start, Lohit?
Yes, sir. Good evening, sir. Myself, Lloyd from Kilpack Medical College. It was a wonderful lecture, sir. My first question is to Professor B.S. Ramakrishnan, sir. So there is a subgroup of patients like patients with CKD, CLD, chronic pancreatitis with exocrine endocrine insufficiency who are on who are having a long-standing disease. Can we most of them are present with diarrhea. For example, in chronic pancreatitis, we label them as steatorrhea and giving on PERT. But sometimes we identify a lot of pathogens during examination. So should the diagnostic approach for these subgroup of patients should be separate, or can we just put in this group of algorithm which you have mentioned, sir?
No, so they would not necessarily go into this algorithm because what you're talking about is two concurrent pathologies like exocrine pancreatic insufficiency along with, let us say, a small bowel infection. And I think you have to treat both separately with the caveat that, for instance, an exocrine pancreatic insufficiency can be secondary to a small bowel disorder because that reduces CCK PZ secretion. Therefore, it can induce a functional pancreatic insufficiency.
Okay. Dr. Vignesh?
Good evening, sir. My doubt is on actually in histopathology, chronic diarrhea, non-infectious causes. In histopathology, there will be apoptosis both in graft versus host disease. And then it may due to that mycophenolate mofetil also. How to differentiate between those? To Ramakrishna, sir.
Yes, so the settings are actually quite different because GVHD is mostly in bone marrow transplant recipients who won't be getting mycophenolate. So the mycophenolates are more in solid organ transplant recipients like kidney and liver transplants. So usually there's not much of a difficulty in differentiating, but sometimes you just have to then stop the medicine or reduce the dose and see.
Okay, thank you.
We'll start the second round. Hereafter going to be a very brief question. We'll start with Dr. Hariharan again, then Chetan Bird will go through the other panel.
Sir, question to Dr. BSR. Just how quickly would you latch on to a flexible CGI or a colonoscopy in your patients, and where would you rule one in favor of the other?
So firstly, I would not use a flexible sigmoidoscopy. I would always prefer an ileocolonoscopy, except in something like acute severe colitis. So I would always prefer an ileocolonoscopy. So how quickly
will you latch on? Will you start? Will you do the test?
So in practice, what will happen is what we tend to do the upper GI and the ileocolonoscopy on the same day. So it usually, as I'm sure you do.
Yes, sir. This thing is that will you do it? Waiting for 4 days, or will you wait for a couple of weeks or 3 weeks, or what will be your time frame before you start doing?
No. If the initial stool tests and all that are negative, it's to go straight away to that.
Straight away.
You don't need to wait long. No.
Okay.
Before Chetan asks, Uday, very diagnostic characteristic lesion you see upper GI and call, okay, this is what it is. Even biopsy also may not be needed. What are the things? A lot of postgraduates are watching. The endoscopic examination, so characteristic pathognomonic lesion. Where, okay, this looks like CME virus.
Sorry, are you asking me or is it Dr. Uday?
Asking you.
Oh, yes. Okay. Okay, I heard it wrong. Okay, sorry. Yeah, so pathognomonic, very often we may not really see anything. So what are the things that what are the things that the only thing pathognomonic will be that, if you see candida, that will be pathognomonic. But CMV, there's nothing very pathognomonic about it.
I think in
Okay.
celiac disease, the folds may be reduced and there may be crenated folds. In celiac disease. In celiac disease, the duodenal folds may be atrophic folds and there may be crenated. From the without a biopsy, you can make a suspicion that could be celiac disease.
In celiac disease.
Yeah.
So the diagnosis actually for, I mean, in practice, if we send a biopsy today in the morning, tomorrow morning we have the report. So it doesn't bother us very much because it comes so fast.
Yeah, so can I also chip in here? You see,
Yeah.
a celiac disease, unfortunately, is not diagnosed by scalloping, because scalloping or reduced duodenal fold can happen in all diseases causing malabsorption. Celiac really require one, that you have histology, two, response to withdrawal of gluten and gluten-containing food, and three, exclusion of other causes of malabsorption. But if you want to know what are the pathognomonic diagnosis histologically, it will be abetalipoproteinemia, agamma-globulinemia, giardiasis, strongyloidiasis, eosinophilic gastroenteritis, intestinal lymphangiectasia, and sometimes
Diagnosis.
To Dr. Uday, your question to
Uday, my question to you, one for the PG student, what are the common mimickers of IBS in the practice they have to consider, number one? And number two, is there any biomarker in pipeline which can diagnose or see the response to your IBS treatment in near future?
Yeah, so both are very good questions. So the mimicker will differ depending upon which type of IBS you are talking about. Let us say if you are talking about diarrhea predominant IBS, mimicker would be several. For example, malabsorption due to any cause. For example, collagenous colitis, microscopic colitis, even early IBD, particularly Crohn's disease, small intestinal bacterial overgrowth, and so on. So all these conditions can cause diarrhea. Even food allergies and food sensitivities may also present like IBS. If you are talking about constipation, then we'll think about the close mimicker will be visceral myoneuropathy causing colonic inertia. Second would be fecal evacuation disorder, or maybe a combination of the two. So these are close mimicker for IBS-C. Sometimes endocrine disorder, uncontrolled diabetes, they can also present with constipation. And very important is to look at for the drugs. For example, many anti-diabetic, they can cause both diarrhea in particular, but may also cause constipation. Now, biomarkers are several, but unfortunately, no biomarker could stand up to the test of the time, because IBS is a heterogeneous condition. It is a syndrome and not a disease. But if you talk about post-infection IBS, anti-vinculin antibody and anti-cytolethal toxin antibodies have been found to be biomarker. If you talk about the constipation, slow colonic transit, and excessive breath methane are biomarker, but these are not typically used in practice.
Now we'll start with Nirmal, then Mahapatra and Yogesh in that order. Nirmal, you have a question?
So my question to Professor Uday Ghoshal. Sir, one of the important subtypes of IBS is the post-infectious IBS.
Yeah,
So,
please.
does the management in post-infectious IBS differ from the common garden variety? And is it easier to treat compared to the other versions?
So all three good questions. So post-infectious IBS, we changed the terminology. It is now being called as post-infection IBS, The reason is it cannot be transmitted from one person to another. Now,
Right.
post-infection IBS more often is diarrhea predominant type. It basically means that either it will be diarrhea or non-C IBS. C IBS is very uncommon. In fact, in one of our studies in gut, we found that after COVID, actually people lost their constipation because they developed
Okay.
some degree of diarrhea. So it is predominantly diarrhea predominant disease. If you say what are the treatment options, since these are mostly diarrhea predominant IBS, you treat with all the drugs that are used for diarrhea predominant IBS because there are not many randomized controlled trial in post-infection subset. But what happens is if you want me studies, steroid has been found useless. So therefore, no post-infection IBS respond to steroid. Two studies, one from Giovanni from Italy and other from Robin Spiller from Nottingham, showed that peculiarly when you give mesalamine, the post-infection subset may respond to mesalamine. And third is many post-infection condition, they have increased serotonin. So therefore, you can block serotonin with either ramosetron or ondansetron. There is a randomized controlled trial from China where they found dietary glutamine to be very good in post-infection IBS because it is an immunomodulator. Now, prognosis-wise, there is one study from China. There are two studies from South Korea which showed, interestingly, post-infection IBS has a better prognosis than usual type of IBS. They sometimes lose their IBS in 5 to 7 years. So therefore, the prognosis of post-infection is better than common garden IBS.
Perfectly fine, sir.
Mahapatra, you and Yogesh after
Yeah,
that.
I think to Professor Ramkrishna, when there is a CKD patient on transplant, if you get diarrhea, you're telling a CMV serology, CMV PCR will be diagnostic in them. Without a histology, can you make a diagnosis of CMV in those patient if serology is sufficient, or do you have to a histology?
So essentially, I think if you have a positive CMV PCR, even if the histology is not diagnostic, the transplant physicians, because we just send the results back to the transplant physicians, and they do tend to treat these patients. And in my experience, a lot of them have responded.
Because in IBD, what you find is CMV colitis, and we have to take biopsy to see coli inclusion bodies there.
Correct.
So,
correct. Because in IBD, the problem is that CMV may be a carriage in a previously ulcerated bowel. So just treating the ulceration may get rid of the CMV. I think that's the reason why it's different in IBD compared to transplant patients.
Thanks.
okay, thank you.
Can I ask
Your
Uday one question?
Yeah,
Uday, by the time IBS patient is referred to a gastroenterologist, they have very severe IBS or refractory IBS. So how early do you use psychological therapy?
I'll tell you that you see, we typically tend to find out psychological markers. So even simple interview can give you a lot of ideas. And the second thing, we look at the coping mechanism. Like any psychologist or psychiatrist will do, how much is the family support? Second is whether he's depressed or not. Is there a sleep disorder? And all these you have to correct. But typically, we do not send them to psychiatrists at all. Because unfortunately, in India, there is hardly any GI psychologist or psychiatrist. The problem is the moment we send to psychiatrists, they tend to give psychopharmacological therapy in high doses. And then this patient do not return to us. Second problem is obviously there are stigma with psychological issues. And the third thing is that if many of these patients have insurance, and the moment you officially refer them to a psychiatrist, the insurance become null and void. So what you have to do is you have to yourself treat. So you have to really have a good understanding of some psychopharmacotherapeutic agent. For example, I typically use among tricyclic antidepressant, I typically use something like amitriptyline and nortriptyline. Now, among SSRI, I typically use something like escitalopram or Nexito, and the second is something like a prothioadine, and the third group is I typically use venlafaxine for patients who require an SNRI. SNRI typically use when the pain is a major problem. Also, sometimes combination of nortriptyline and pregabalin, there are randomized controlled trial on pregabalin, they relieve pain. And when somebody has appetite, which is a major issue, I give mirtazapine because mirtazapine increases appetite. All the therapies that I give in a very small dose. Sometimes I call the family together to have a talk, to increase the coping mechanism, to increase the family support. There could be a secondary gain that when the patient falls sick, maybe his or her near and dear cares for more, and there could be a secondary gain. All this has to be taken into consideration. And we have our support system, which is not really all psychiatrists, but it's really something like dietary therapists who also do a little bit of support. And then they tell me, sir, this patient has a real issue in his or her family.
I think this is a fantastic answer, Uday. Psychopharmacological drugs in smaller dose you can use it. The moment you send to psychiatry, they think it's a very big problem and we lose the patient. Or as you said, they become over sedated and they don't come back. That's very good. I think we need to take a clue from that. I think we should be all gastroenterologists be well versed with the psychopharmacological.
Yeah, the other way is that we should, we are trying that. Other ways that we should have psychiatrists who work with us and gradually becomes a little oriented in these diseases. And we should have psychologists who should closely work with us.
Okay. I think
like
that
dietitian.
is,
They will love BGP.
GI psychologist, psychiatrist, and that's good, but you're not having that, not everyone has got a luxury, or they also don't want to treat such a minor cases also sometimes. Yoga, your question too. Now hereafter, we should have very brief answers.
Yeah,
okay.
This question to Professor B.S. Ramakrishna. So, in practice, do you usually use anti-motility or antidiarrheals like loperamide when you come across patients with diarrhea and an immunocompromised state? Are there any precautions that you usually follow, or you avoid them completely?
I would prefer to avoid them completely unless I know it's a non-infective cause, then I might be tempted to use it.
Okay.
What if the diagnosis is not very sure?
Yeah, that's if you excluded infections, then it's fine. Because, the diarrhea is one way of getting rid of the pathogens. It's body mechanism to get. So, in an infection, I would not like to use an antimotility.
I will put it as what Rama said. If the diagnosis are not certain, also we shouldn't use the loperamide. And the non-infectious causes, I think, as you said, will be the loperamide can be used. Okay. Lohit and Vignesh, quick questions before we start the ultra short rounds for 2 minutes. Okay. Quick questions.
Yes. Sir, this is my question to Professor Uday, sir. How often you label someone or else what is the prevalence of a patient with IBS in elderly more than 60 years?
Okay. Elderly
IBS is not uncommon, I'll tell you, not uncommon. If you look at the population prevalence of IBS in India, it is typically between 1 to 4%, and elderly, obviously, a small part of them, maybe around 0.1 to 0.5%. What I'm saying is not uncommon, but only thing is in elderly, I'll be very careful because age itself is an alarm symptom. So I like to investigate. And the second thing, many of them has comorbid illnesses which can cause IBS-like symptom. Third is they may be on multiple drugs which can cause IBS-like symptom. And the fourth is they may have slow motility and all those.
That's a very important point. Elderly before making IBS diagnosis, rule out malignancy or organic
Yeah.
before taking the over diagnosed IBS. Vignesh, what is your point? What is your question or comment? Quickly.
Good evening, sir. How to personalize treatment among the secretory drugs, bile acid modulators and the serotonin modulators? How to personalize? How to put in the first treatment? How to in IBS?
Yeah, you see, very good question. So if you are talking about IBS-C, what are the choices, particularly if usual therapies have failed? It is linaclotide, plicanatide, and the third is ilobixibat. These are the new drugs. So if somebody has pain with constipation, I will choose linaclotide. The other choice could be plicanatide, but the plicanatide is very expensive. It is almost 140 rupees per tablet or capsule. So therefore, I will go to linaclotide. They are similar drugs. On the other hand, if the pain is not a major problem, it is ilobixibat. There is no head-to-head trial on ilobixibat versus linaclotide, but my personal experience is ilobixibat is more effective than plicanatide. When it comes to diarrhea, I tell you, my first drug after the usual is ramosetron, very effective. But if somebody has upper GI plus lower GI symptom, I will choose ondansetron. If you look at the Robin Spiller study in gut on ondansetron, he used a dose which is 2 milligram thrice daily, and then he allowed the patient to increase the drug at the patient need. So here also I will empower my patient to increase the drug. If it is an elderly, I'll be careful because ischemic colitis is a side effect of both ramosetron and ondansetron. The other choice is bile acid binding agent, particularly if ramosetron or ondansetron is not effective, I'll add a bile acid binding agent. And I tell you, almost 90 to 95% patient, I find it is effective. And often they come to me saying that, doc, I have now constipation.
I think what dose you use for constipation? Constipation, you use this
Which one? Which drug are you referring to?
290 linaclotide.
No, I don't give 290. What I do is 72 microgram, either 2 or 145 microgram 1. 72 microgram I prefer because I have more flexibility in increasing the dose. Because 290 often causes diarrhea. So therefore, I'll say 72 microgram, 1 increased to 2, and then 3, and so on. There are randomized controlled trial between 145 and 72, and it found 72 do even reasonably good.
Okay, now we are coming to the last part of it. Sorry, Mahapatra. Which is more common quick answer, functional constipation or IBS-C?
Can you repeat what you said?
Which is more common, functional constipation or IBS-C?
In India, functional constipation, according to Rome 5, which is called chronic constipation, is much more common than IBS-C.
Actually, I just wanted to drive home here is IBS-C is much lesser when compared to functional constipation.
Yes,
chronic
because IBS-C means pain plus constipation. Functional constipation, which is called chronic constipation, is no pain. And functional constipation is much more common.
Chennai also constipation without pain. And I mean, less commonly we see this one. Okay, now we are going to more.
Uday, how difficult it is to practice low FODMAP diet in India?
Very difficult. I tell you, very difficult. In West Bengal, till better. In UP, it was so difficult that 90% people are vegetarians, and the wheat is very important to them. So question is, in West Bengal, it is better. In fact, we have divided the country in one of our papers according to the difficulty level. And in northern India, it is most difficult. In southern, in eastern and northeastern, it is much more easy.
Have 5 minutes, no more. We have enjoyed the academy session. Now the question to all the panelists, start with Rama. What was the turning point in your career? Quick.
I'm not sure what a turning point in my career was. So I guess it remained when I decided to take up gastroenterology. Perhaps.
Okay. one thing. And what is the turning point, Uday, in your career?
Yeah, so actually the two turning point. One is my math teacher actually slapped me. I did not do anything wrong, but it was a mistake on his side. That's why I went into medicine. Otherwise, initially I was interested in math. That was one turning point. The second turning point was I came to SGPGI when I learned all research, because before that research was not the main thing. So the turning point was SGPGI entry for DM.
Okay, what is, Hari, your turning point?
Returning back, sir. 20 years ago, after I decided to return back to India, that's the turning point, sir. I really feel, I felt much better back home.
And what is Chetan? What is your turning point in life?
My turning point, I had taken up DM Neuro first. I almost did 1 year of DM Neuro. Then I realized that Gastro is better. So I left DM Neuro and took over Gastroenterology.
Okay.
Sir.
So you should be a neurogastroenterologist.
Absolutely. That is why I'm in IBS. Neuromotility disorder.
Yeah, that's right. That is neurogastroenterology.
Nirmal, what is your turning point?
So building a team of GI colleagues around me, and that's our strength now in the whole region.
Okay, turning the point is your team. Mahapatra, your turning point?
Yeah, again, thinking of this gastroenterology, when I was in PGI, I thought of doing neurology, but I found it's a dry subject. Only diagnose, discuss, and discuss. No treatment was there. So I.
Gastroenterology over neurology was your turning point.
Yeah.
Okay, you are young only, but still.
It's yet to come, sir. I'm hoping it will come in the future.
Lokit and Vignesh also yet to come. Okay, what is the non-medical book you have read recently, Rama? Non-medical book you have read.
Yeah, so that would be Species
Okay.
by Yuval Noah Harari.
How do you get time for this?
No, I read every night, so it's a gripping book. I mean, I couldn't put it down.
Okay, quickly. And Uday, what is the non-medical? You are a voracious reader and writer also.
Yeah, so I read Rabindranath, I read Jivanananda, I read Sarat Chandra, all the novel and poetry
What you have read
of
recent?
literary things, because I'm publishing two poetry book. 5th July is one, and the
Yes.
second one is maybe end of the July, two poetry book of mine.
What is the non-medical book you have read?
Non-medical book is Rabindranath Tagore, I said. Sarat Chandra Chattopadhyay, I said.
Thank you. Chetan, what is the non-medical book you have read?
I think most of the religious book I read, but not any other specific book.
Okay. Hari, what is the non-medical book?
No, I keep reading about Kannadasan. There is a Arthamulla Indumadam. That's what I keep reading most times.
Tamil literature written by a poet in Tamil, Kannadasan. Nirmal, what is the non-medical book you have read?
So very recently, sir, Atomic Habits by James Clear. So it's a tiny changes, remarkable results.
What is the book about?
This is all about making little changes in your life which give rise to remarkable results. Atomic Habits.
I was seeing my neighbor was studying in the yesterday.
It's an excellent book.
Very good.
It's an excellent, very gripping, and it's a mind-changing book.
Okay, right. Mahapatra, what is the non-medical book you have read?
Yeah, I usually read mythology books, for example, Ramayana and Mahabharata, sometimes with that.
What is non-medical book?
Yeah, there's a book called Dopamine Detox.
What is the
Dopamine Detox? It's lent by Dr. Gokul. I'm going through that.
No, what?
It's called Dopamine Detox, sir. It's a
medical,
sort of a
non-medical?
self-improvement book. Non-medical book. Non-medical book. Dopamine Detox got nothing to do with
the dopamine.
neuropsychiatry, no.
So now, TSC, we need to ask you, what is the latest medical book you read?
I'm an environmentalist. I'm reading on environmental. I took a lot of interest. And WHO, I think first time you're asking the chairperson also. The WHO team has come with the 2026. I think Many did not go notice into that. One health chain is going to affect human, plant, and the animals and the planet. So you make one good thing, it is going to do good thing for everybody. You make one bad thing, it is going to affect the plant, planet, and the animals. So I am reading that book. So I get a lot of ideas, and the WHO has mentioned that 365 you have to celebrate for a year. So now we are coming out of the 365 initiative, one per day we are coming out. And I would have sent it by the digital platform. One initiative a day for 365 days. It is mind blowing. It is fantastic actually. Today also I've sent one mail. I mean the digital platform about the you have to plant and encourage the planting mangroves tree the coastal area, something like that, which will affect the so one health chain is that is the one. And now I'm going to ask a little more interesting question. Who is your heroine, BSR?
My hero? Oh, that's a difficult question. I haven't actually really thought about it, TSC. Can I come back last?
Huh? You want to pass the question? Huh?
I'll pass.
No, I thought you will say your mother.
Easy.
Right. Uday, who is your heroine?
Yeah, difficult question, but I'll still tell you my mother and my spouse.
I gave a clue, so you took up the clue.
So if I give a clue, who asked you to give the clue?
I shouldn't have given the clue. What? Chetan, who is your heroine?
My wife.
She is around you there?
No, she's in other room.
No, it is being recorded. You see, he's recording it and you later.
Hari, who
Sir, obviously my wife, sir.
is speaking from whom, I think.
No, this question TSC is now out. So
Story.
this question should not be asked. It is out. Question has been out.
Who is your Why everyone is blushing and shying? I don't know. Irritable, who is your heroine?
Sir, I go with my mother and my spouse. Same as Uday said.
It's a copy question.
Safest answer.
Copying is not allowed. Copying is not allowed.
Apatra? Oh, you are taking so much of time. Wife is around. Huh?
Hey, you're muted. Jyoti, you're muted.
Conveniently muted.
No. Actually, son rang me that time. So
What's that?
my son rang me that time, so I just was talking.
No,
to him.
who is the heroine?
My wife, obviously, yeah.
That is the question because when
Everybody is copying.
Clearly to answer.
TSC, change your question.
Huh? Yogesh is not answering. Huh?
Yeah, Preeti, I don't think she's watching. So it is Simran, sir.
Simran. Okay. And the last question of the day is one word answer. Work-home balance or work-life balance? Rama.
Work-life balance, work-home balance, I guess, yes.
One word answer. How you manage?
How do you manage?
That's the question.
I'm not sure I manage very well. I'll have to ask my wife what she says to that.
What is your work-home balance?
Whom are you asking?
You, Uday?
My answer is by multitasking.
Multitasking. Very good answer then. Chetan, work-home balance.
I think more family now. Work reduced now. More family.
More family, right? So when you are at the peak of your career, still you are in the peak. How do you manage work-home balance?
I think what Uday says is perfect, multitasking. Because I also look after many.
Hari, what is your answer?
Mine, sir.
Lot of people from all over the world watching. They all want to see the pioneering speakers and moderator panelists, how they manage it. So going to percolate.
Come on,
Sir,
Hari.
I've,
You have to
I've been
talk.
I've been trying to do since I started working, but I am yet to reach, sir. Someday I will reach, hopefully, sir.
Here to reach. Okay, Nirmal.
So, sir, always finding some me time and the family time along with the work.
Me time is what you only.
Investing in your hobbies, maybe like sports. World Cup football is going on, so even you watch it for half an hour, it actually rejuvenates you.
Quality time for me and family time.
Yes.
Mahapatra,
Yeah, I don't work in the evening. I finish everything by 6 p.m. so that I come
you have
back
enough
home
time.
and have
That's
family
not
time.
Does it create problem?
Yeah, more family time.
Yogesh?
I think I bring a lot of work to family in the sense that I share a lot of things which happens in our hospital. So that makes treating more understandable of how things go on over here. So that's over bad. So it's opposite of compartmentalization, somewhat of that sort.
I've already taught them so many things about compartmentalization. Once you go their home, you are now with their family. And when you are in the hospital, I make a point that not to
Discuss.
too much of the calls from home or this one. Compartmentalize is the one I practice. I'm very happy to tell that because I'll be happy telling. I think, ladies and gentlemen, that we had delegates from all over the world. One of the fantastic webinar because the two topics were diarrhea is still very evasive and elusive and immunocompromised, and particularly when you have a organ, the hyperacute rejection is there, and Rama, as usual, did a fantastic job. And Uday, the art and science is so important. IBS is still, I would always look at the patient, is he happy with my treatment or not? Then I'll ask my nurse, what is the feedback from the patient? Is he happy going there? Then I will carefully look for the Google review, what he has written about IBS treatment. See, organic problem, we know that the patient becomes all right, or we know our assessment. In IBS patient, I am very particular about it. That one way of assessing that maybe Uday can come out with the another paper with a Google review and the IBS patient without the. So that is gives me enormous this one, and Uday did a fantastic job. And Hari, we did a fantastic moderation. Chetan from Los Angeles, and you did not miss this. I was a little worried. And Nirmal and Mahapatra and Yogesh did a fantastic job. I like that how you all blushed and they became very shy when talking about the heroine. Period questions, but I will not answer now. And the two PG young the faculty. This is the first time I'm introducing PG faculty system that brought me, that is bringing me a lot more the delegates from the PG circle. So I think we enjoyed it and fantastic. And it all will be available in the YouTube, and you enjoy this. And don't miss the next month, July, none other than Patrick Common also is going to speak on how did he discover MEL score and what is all. Thank you very much. And bring warm greetings from ACG and convey all your regards to American College of Gastroenterology. And you go to the website, it is mentioned in the ACG, all our webinars. Thank you very much. Thank you very much.
Good night. Good night.
Bye-bye.
Good night.
Thank you, sir. Thank you, TSC, sir. Thank you, BSR, sir.
Thank you, sir.
Bye, Hari.
Thank you, everyone. I see you, Jyoti. Bye-bye.
Thank you. Bye bye. Thank you, sir.